normal differential white blood cell counts. A white blood cell count, just the number, is the number of white blood cells in your blood, and normally it's going to be about 6,000. If you look, where is it? 6,000 or 5,000 to 10,000 is normal. So in terms of, I'm going to come back to this, but in terms of a white blood cell count, if it's above 10,000 per microliter, or cubic millimeter is the same thing, it could be due to some kind of infection in the body or some other disease process, allergies, inflammation, and so forth. It could also be due to leukemia. We'll talk more about that in a second. Leukopenia is lower than 5,000 per microliter total white blood cells. And this is usually due to something that's suppressing the immune system or holding down the immune system. This could be due to human immunodeficiency virus. It causes AIDS. That's going to cause leukopenia. Bone marrow failure, if the bone marrow is not producing enough red blood cells for some reason. This can happen for a variety of reasons, including exposure to radiation. If you're exposed to high levels of radiation, like from a nuclear bomb or something, that can suppress your bone marrow and could cause that to happen. Chemotherapy, some chemotherapy drugs cause suppression of the bone marrow and cause low white blood cell counts. And it means that you'd have a harder time fighting infection. Also, if you were on immunosuppressants for some reason, let's say you had an organ transplant and your body is trying to adapt to that new organ, like the heart and lung or something like that, the doctors would put you on an immunosuppressant to prevent too much inflammation and also to prevent you from rejecting that organ. That could cause you to have leukopenia, so you'd be more susceptible to infection. Now, if you want to know more about what's going on in the body, you do a differential white blood cell count, which is a percentage of specific white blood cells, not just the total number, but the specific number of white blood cells, which can give you an idea of what kind of infection or problem there is. If you have elevated numbers, a differential can tell you what kind of problem. Is it an infection? Is it a bacterial infection? Is it a viral infection? Is it a tapeworm? It can tell you a lot. It can also tell you, in some cases, that you have leukemia. Leukemia is a cancer that begins in the red bone marrow. Some of those stem cells in the red bone marrow can start to divide out of control, releasing too many of that type of red blood cell or white blood cell. It's usually a specific type of white blood cell that you see elevated in numbers. You might see an elevation in neutrophils or an elevation in basophils. It just depends on the type of stem cell that's growing out of control. This also elevates the number of immature white blood cells. You'll actually start seeing immature white blood cells in the bloodstream if the person has leukemia. That's an indicator of leukemia when you see immature white blood cells as well as the mature ones in higher than normal numbers. But most of the time, an elevation white blood cell count is not leukemia. Most of the time, it's some kind of infection, allergy, or some other thing going on. Low white blood cells count, as I said, can be caused by various things, that suppress the immune system. Now, so here is a table that you can look at. I don't expect you to memorize it, but it does tell you high numbers. If you had a differential white blood cell count that showed high numbers of neutrophils or high numbers of lymphocytes or whatever, what high numbers might be due to versus low numbers, what that could be due to. So you might just want to look at that just to see what kinds of things can cause high or low, elevated or abnormally low numbers of these cells. And notice that in some cases burns, because not only is it a stress, you're stressing the body, but there's also infections. Burns lead to infections. So typically burns and infections end up going together, and you get elevations in neutrophils and some of the other cells. Now, in some cases, when there is a abnormality, such as leukemia, but it can be other things as well. If certain disease processes involving the white blood cells don't get remedied by chemotherapy or other drug therapies, sometimes you have to resort to a bone marrow transplant. Bone marrow transplants can be used not only to treat leukemia. Recently, there was a bone marrow transplant used to treat a person with AIDS and help clear out their HIV infection. But usually that's not done. It's very rare, and it's also, one problem with bone marrow transplants is they are high risk in terms of survival. A lot of people die from bone marrow transplants. But if you're taking chemotherapy drugs and that's not clearing out the leukemia, getting rid of it, then they may resort to this. What they have to do then is radiate your bone marrow, get rid of it, try to wipe out your red bone marrow, and then they inject into your body a donor's red bone marrow. And this is tricky because you have to match up a lot of antigens, what are called MHC proteins that can trigger graft versus host disease. You have to try to get somebody who's got very similar antigens in their red bone marrow as you have. And in fact, there's a bone marrow registry. If you donate blood, you can sign up or you could probably do it without donating blood, but they use that blood to determine your MHC protein antigens. And you can sign up for a bone marrow registry, and if somebody needs a bone marrow transplant and their relatives don't match them, they will go to the registry and find somebody who is a close match and ask that person to donate their red bone marrow. So if you're interested in doing that, there is a bone marrow registry that you can sign up for. And what they do is they take the donor's bone marrow, usually out of the hip, and they inject it into the recipient, after first radiating the bone marrow and killing off the donor bone marrow, the recipient's bone marrow. They then inject a donor's bone marrow to replace it, and it takes some time for that to grow back, and start elevating your blood cell counts. You have to be under sterile conditions because potentially you're going to be you're going to have a weak immune system. You have no immune system for a while, so you have to be under very tight sterile conditions during this process. You also, they have to watch your blood cell counts, your platelets, your red blood cells, all that stuff, because all of that's having to come back to replace your original bone marrow and your platelets and all your blood cells, all that stuff. There is a high risk for graft versus host disease because in some cases the T cell lymphocytes from the transplanted tissue will start attacking your own body. Or if they leave a little residual bone marrow behind after radiating it, that bone marrow may start producing T cells that attack the bone marrow. You can have different kinds of attacks. So either way, it isn't good because that means either they have to, re-radiate and re-transplant, or you're going to die of host versus graft versus host disease. So red bone or the bone marrow transplants often have a higher than average risk of that happening. Now, cord blood transplants, some people will have the blood from the umbilical cord at a baby's birth. They'll save it, have it frozen away, just in case that child at some point in time has leukemia. They can then take that blood and grow from that blood stem cells that can replace bone marrow, and that greatly reduces that graft versus host problem. It's expensive to do, and you're just kind of doing it just in case. Maybe it's a good idea if leukemia runs in the family or something like that, but most people don't bother doing it. But it is a way of fighting leukemia in the future if a person did in fact have leukemia for some reason. So some people do cord blood transplants where they'll freeze the umbilical cord or the stem cells and freeze them for later, but it does cost some money. Okay, so here's some summaries of formed elements. This is just a table that summarizes this information about erythrocytes and leukocytes and the information about them that you can use, just as a nice tight summary. We're going to look at platelets next. Any questions about leukocytes? Or move on. So platelets, again, these are not true cells. They are cellular fragments, 150,000 to 400,000 per microliter of blood. They're smaller than a red blood cell. You know, red blood cells are 8 micrometers, they're 2 to 4 micrometers. So they are very, very tiny. And they're used, of course, in the blood clotting mechanism. They come from this cell line here. The myeloid stem cell develops into this giant cell called a megakaryocyte. Mega means large. These are very large cells, and they fragment into platelets. So little bits of the cytoplasm and plasma membrane break off, and they just fragment and release those platelets into the bloodstream. And platelets don't last a real long time because they're not real cells, so they only have a very short lifespan, a matter of days in your bloodstream. But they're being produced all the time, and then broken down by your spleen and liver over time. So as they age, they get taken out of circulation. Your spleen and your liver take out old white blood cells and red blood cells and platelets all the time as they're being replaced. Platelet production is under the influence of thrombopoietin. Thrombopoietin is a hormone that stimulates the pluripotent stem cell to go through this pathway of development. So thrombopoietin, remember thrombocyte means platelet, so thrombopoietin is the hormone or growth factor that stimulates megakaryocyte production. And so the megakaryocytes produce about 2,000 to 3,000 cell fragments that are released into the bloodstream, and your platelets only last about 5 to 9 days before they're taken out of circulation by your liver and spleen. Hemostasis, this is the process of stopping a bleed, if you're bleeding from some injury. There's 3 mechanisms that reduce blood loss. One is vascular spasm. This is the response your blood vessels have when they're injured or there's an injury and you're bleeding. They will spasm, meaning they will constrict. So vasoconstriction of the blood vessels helps reduce blood loss. And then you have platelet plug formation. Platelets form a plug that is a temporary plug to prevent blood loss. From that plug, though, you get a blood clot. So first you get a platelet plug, then you get a blood clot out of that platelet plug. And so blood clotting or coagulation is that. So now this is in an undamaged blood vessel. This is a blood vessel. Any blood vessel in the body, an artery, a vein, a capillary, is going to have endothelium here inside the wall. Now capillaries are just pretty much endothelium, but arteries and veins are going to have connective tissue over here. And the endothelium is simple squamous epithelium. And this is the connective tissue. Here's the blood. So the blood is circulating past the endothelium, which is that lining of the blood vessel. Endothelium produces, when it's undamaged, it produces 2 local hormones. Prostacyclin, also called PGI2, is a prostaglandin, and prostaglandin is a local hormone. So is nitric oxide. And what these 2 do is prevent platelets from forming platelet plugs inappropriately. So it prevents platelet plug formation or production, and it also prevents constriction of the blood vessel. So these act as vasodilators. Not only do they prevent blood clots from forming, but they also act as vasodilators, keeping the blood vessels nice and open, or not open, but wide, so blood circulates. So that's under normal conditions. Nitric oxide, by the way, is the same thing as the laughing gas the doctor gives you at the dentist. If you take nitric oxide at the dentist's office, it's the same thing. But nitric oxide is actually a local hormone produced by the endothelium. Now, what happens if you damage a blood vessel? Damage to the blood vessel, like a cut or an injury or some kind of internal thing happening in the blood vessel, exposes, so let's say right here some endothelium is missing because you have an injury, you've got a cut or something like that in your skin, and that damages the blood vessel. The platelets, which are these things here, all those are activated. I guess these are supposed to be, I'm not sure if those are platelets or red blood cells. Oh, let me back up for a second anyway, because there's labels here. Okay, so these are supposed to be inactive platelets, even though they look like red blood cells. I don't like the drawing. But anyway, I want to point out one other thing. This brown stuff here is collagen, which you're going to find in connective tissue under the endothelium. And the blue dots are, which are labeled VWF, are von Willebrand factor. Okay, so it's not in this next picture here. So there's the collagen in the connective tissue. The blue dots are von Willebrand factor. When you expose the collagen to your platelets, when they are exposed to collagen, they will undergo what's called platelet release action. They become activated, and they start producing chemicals to set into motion the formation of a platelet plug and then the formation of a blood clot. So the chemicals that are released by these activated platelets are ADP, which is adenosine diphosphate, serotonin, and thromboxane, I'll say it right in a minute, A2, which is shown here as TXA2. And these chemicals bring on what's called the platelet release reaction, the reaction to this platelet release of chemicals. Now, notice one thing about the von Willebrand factor, it helps the platelets stick to the collagen to generate a platelet plug. And one type of hereditary blood clotting disorder, the most common blood clotting disorder, is not hemophilia, it's von Willebrand disease, where you don't have these von Willebrand factor proteins, or you have a reduced number of them, and so the platelets don't stick to the collagen as well, so you don't form that platelet plug as well, and you don't activate those platelets. So this is a fairly common hereditary disorder that a lot of people have. It's also a dominant disorder. If you inherit the gene, you have the disorder. So it's more common than hemophilia. Now, the platelets stick to the collagen, and that's facilitated by the von Willebrand factor here in blue. The platelets rupture and release these chemicals, ADP, serotonin, and TXA2. And those chemicals that are released, by the platelets. So here's an undamaged, I guess it's a little damage there. The collagen activates the platelets, causing them to rupture and release their chemicals. And those chemicals bring on vasoconstriction, which helps reduce blood loss. These platelets will now stick together, forming a platelet plug that temporarily closes up the wound. And then from there, the platelet plug undergoes blood clot formation. So you're setting into motion the blood clot, but a platelet plug by itself is not a blood clot. A platelet plug is kind of a temporary plug to stop blood loss, but by itself, it could dissolve and go away. So you have to have a bit more sturdy structure, which is a blood clot. But from the platelet plug, you'll get the blood clot. Now, a blood clot consists of, and I think I skipped a thing. Okay, a blood clot blood clotting is actually a pathway of events that converts the plasma protein fibrinogen, which I mentioned in the quiz today. It's a soluble protein. It's dissolved in the blood plasma. It gets converted to insoluble fibrin, these fibrin threads. So when you start the blood clotting mechanism, first of all, you have that platelet plug, and the fibrinogen gets converted to fibrin. So here you see the formation of fibrin threads, the beginning of a blood clot formation, and then those fibrin threads get thicker and denser, and you get red blood cells caught in here as well as the platelet plug that you started out with. So this is happening within the platelet plug. You get these fibrin threads holding all that together. You get trapped red blood cells, and then the fibrin threads constrict, squeezing out fluid called serum. Where is that? Blood serum. You sometimes hear that term used. Serum is blood plasma that's squeezed out of the blood clot. It contains everything in blood plasma except for fibrin or fibrinogen, because the fibrinogen has been converted to fibrin. So blood serum is this fluid that's squeezed out of the blood clot, causing the blood clot to harden and tighten up and seal off the injury. So this is, so a blood clot is not just a platelet plug, it's a meshwork of fibrin threads, around these platelets, as well as around some caught red blood cells that get caught up in the mix, which those red blood cells give it that red or reddish brown color. So the picture here, the yellow is the fibrin, and you can see red blood cells. You really can't see the platelets. Well, there's a few blue ones up there that they've colored blue, but can't really see them very well in this picture because they're so small. Now there's two pathways, and you're not gonna have to memorize all the steps. I'm just gonna kind of give you an overview of it. There's the extrinsic pathway. This happens anytime you have a cut or an injury where there's an injured tissue, either internally or externally in the body. And your tissue starts producing, your damaged tissue produces a blood clotting factor called tissue factor, which sets into motion what we call the extrinsic pathway, meaning from the outside. In other words, injury happening in the body, either it can be during surgery, or it can be from a cut, whatever kind of, or from a trauma. Any kind of injury of tissue is going to set off the extrinsic pathway. The intrinsic pathway happens within blood vessels when a blood vessel is damaged and there's exposure to collagen, like we were talking about. Anytime you have injured tissue, you're going to get damaged blood vessels, and you're going to get platelet plugs that way. But you're also going to get what's called the intrinsic pathway. So there's the extrinsic pathway, which is the tissue pathway of blood clotting, and then there's the intrinsic pathway, which is happening inside the blood vessels. It involves a different set of blood clotting factors. You don't have to memorize all the steps, but there's a different set of blood clotting factors involved in that pathway. Both of these happen when you have an injury. If you have a cut, you're doing both. You're doing your damaged tissue, you've also damaged blood vessels, you're going to get both pathways. You can get this pathway by itself if, for example, you have an atherosclerotic plaque, which is those plaques in arteries that have fat and cholesterol and calcium deposits. If that ruptures, then you're exposing platelets to collagen. When that ruptures, that sets into motion a blood clot, which is one of the reasons why atherosclerosis can lead to heart attacks and stroke and things like that, because you can form a blood clot from those atherosclerotic plaques. Another way is if you're sitting in an airplane or in a car for 5 hours, you don't get up and move around, and blood's pooling in your legs. That blood kind of just sitting there, those platelets moving around, and that pooled blood sometimes rupture by accident and start causing that platelet release reaction, which leads to platelet plugs, which then leads to the intrinsic pathway. So this is why you want to get up and move around, or if people are in bed in the hospital, they put those things on their legs to keep the blood circulating so that you don't set into motion the intrinsic pathway. This is how people get blood clots that end up causing heart attack, stroke, or pulmonary embolism. And so that's the intrinsic pathway there. But usually both are involved. Both pathways function in various steps that activate an enzyme prothrombinase to convert prothrombin to thrombin. Prothrombin is inactive, it's an inactive plasma protein. Thrombin is the active protein. The common pathway, meaning both pathways lead to this pathway. Common pathway is common to both. Thrombin, right here, converts fibrinogen to fibrin. So that's how you get fibrinogen, which is soluble in the plasma, to this stuff. It's not from the platelets directly, it's from that pathway leading to the common pathway. Prothrombin, the inactive protein, gets converted to thrombin, and then thrombin converts fibrinogen to fibrin threads, which consolidate and form a blood clot. So all of these paths eventually lead to this. And the blood clot is supposed to stop blood bleeding, but if it's formed inappropriately, it can, like I said, it can travel in your blood to your heart or your lungs and cause some circulation problems. Notice the little Roman numerals. Roman numerals mean, are referring to blood clotting factors. So there are different blood clotting factors in the steps. Some of them are proteins, some of them are other chemicals, but the blood clotting proteins, the blood clotting factors have a Roman numeral, and I'll show you them in the next picture. And so you need all of those blood clotting factors for proper blood clotting formation. Von Willebrand factor is just one of those blood clotting factors you need, but you need some others as well. Calcium is important. Notice calcium, which is important not only for your bones and for muscle contraction and nervous system function. You need calcium for blood clotting. So that's important as well. So notice on the second page here, you have all these are the Roman numerals 1 through 13. These are the blood clotting factors, and calcium is one of them. Fibrinogen is one of them as well. And these blood clotting factors are needed for proper blood clotting formation. Some of these are proteins made by the liver or made by other cells, and the genes for those proteins are on the X chromosome. And if you have a recessive allele, if you're a male and you have one recessive allele or gene for one of those plasma proteins, you could end up with hemophilia. If you're female, you have to have 2 recessive genes, one on each X chromosome, to develop hemophilia. But there's different forms of hemophilia depending on which of those proteins are affected. So hemophilia is due to usually it's an X-linked recessive genetic disorder, not as common as von Willebrand disease, but partly because it's a recessive disorder, not a dominant one. But it can affect any of those proteins that are blood clotting factors because those genes are found on the X chromosome. And so there's some that are more severe than others. If it's earlier in the pathway, that's going to be a more serious form of hemophilia. Or if it affects fibrinogen or something like that, it can be a very major problem for clotting blood. So the severity depends on the blood clotting factor. There's different kinds of hemophilia. You also need blood clotting, or you need vitamin K for normal blood clot formation, because vitamin K is used to help in the formation of some of the blood clotting factors. Vitamin K is essential for that. This is why somebody's on Coumadin, which is a blood thinner or anticoagulant. They don't want you taking vitamin K or eating foods high in vitamin K if you're on Coumadin, because Coumadin is supposed to stop blood clots. You don't want to stimulate blood clots. So they put you on a low vitamin K diet if you're on Coumadin. Now you do have an enzyme called plasmin, which dissolves blood clots. This helps dissolve unwanted blood clots that can form in your blood. It can also dissolve blood clots once the tissue has healed up. So plasmin is the enzyme that breaks down fibrin. Okay, and finally, blood groups. Finish this up here. Blood grouping is based on the presence of antigens or agglutinogens on the surface of red blood cells. There's 24 blood groups, but really only a couple of them are important in terms of blood donation and things like that. But there are some rare blood groups that some people have troubles with. But the predominant blood types are ABO and Rh factor. And ABO, here's the percentages. I'm not going to worry about that, but you can see how many, in different countries, you have different percentages of these blood types. ABO is due to one set of glycolipids that are on red blood cells. Rh is a different protein antigen that you may or may not have. If I can get this to go. So, if you're a blood type A, you have the A type antigen on your red blood cells. If you're type B, you have the B type antigen. If you have AB, you have both antigens on your red blood cells. If you're type O, you have neither of those, and I'll show you a picture of that in a second. Oddly enough, if you're type A, you produce antibodies against the type B antigen. And if you're type B or AB, you produce antibody against, your white blood cells produce antibody against the type A antigen, because some of the food we eat, some of the plant cells we eat, and some of the bacteria in our digestive tract have similar antigens on their cell surface. And when we're exposed to those antigens, our B cell lymphocytes start producing antibodies against those antigens. and they cross-react. In other words, you know, if you're type B and you're exposed to antigens similar to the type A antigen, you're going to produce antibody against it. Yeah.
Is that where they kind of get those blood type fad diets I've been reading about?
It's partly from this, I think, from looking at the diet of people. Yeah, if you're, you know, if there's different people from different countries have different diets, and I think it's based on that, on the percentages, but it's baloney. I mean, there's been nothing scientific. Yeah.
I'm just wondering if that's where they got the notion from.
Yeah, I think it's from those percentages saying, well, if most people, you know, in Korea are blood type O, then that must mean, you know, then you would want to eat a diet. If you're, you know, type O, you want to eat a diet similar to what a Korean American would
Bring
eat.
on the kimchi.
Yeah, I guess is what it is. I mean, there may be more to it than that, but I think a lot of it's based on that. Now, so you don't produce antibodies against your own blood type, but you do produce against the other blood type. So if you're type A, you have A-type antigens, which shown in purple, you produce anti-B antibody automatically. I mean, it's just because you get exposed to similar antigens in your digestive tract. Type B, you produce anti-A antibody. Your type AB, you don't produce either, so you have no antibody. So if you're AB, you kind of have the best situation because they can put any blood type in your body and you're not going to have an agglutination response. If you're type O, you produce both antibodies. Now, that means that if you get the wrong blood type, if you get type B or AB, your anti-B antibodies are going to attack or bind to those B antigens and cause what we call agglutination or clumping. And so that's what this picture is showing you, that if you're type A and you have anti-B agglutinins or antibody, as long as you're getting type A blood, you're fine. There's no agglutination, no binding. But if you're type B and you've got, and you are, let me see. Oh, you're type B donor and you give blood to a type A recipient, the type A's antibodies are going to bind to the antigen. Okay, so, and it's going to cause clumping of the blood, kind of like that antigen-antibody complex. That's called agglutination. You're also going to get rupturing of red blood cells. This can lead to anemia and can also lead to organ failure and things like that. So that's what they use when they're typing your blood. Real quick, let me finish this up. They are using those same antibodies to type your blood. So they put your blood smear up and they add anti-A antibody and anti-B antibody. If you clump with anti-A antibody, you've got type A blood. Type B blood, you clump with type B, AB. Oh, there's no clumping. Now there's also the RH antigen, and that is a whole different story, but that's A and B right there. So that's how you know your blood type, by that simple blood test. Okay? Now, RH factor, real quick, RH factor is a different story. What happens is, if you're a RH negative mother and she's pregnant with an RH positive baby, some of those little red blood cells get into her bloodstream during childbirth, and she will start producing anti-RH antibody against those red blood cells. That's not a problem for the first birth, but now she's got memory cells making anti-RH antibody. So then later on in second birth, if she has another RH positive fetus, those antibodies cross over the placenta into the baby's bloodstream and cause agglutination responses in the baby's blood, and that leads to hemolytic disease of the newborn, erythroblastosis fetalis. So they give her, an RH negative mom, Rogam, which is an antibody that attacks those red blood cells before she gets a chance to produce antigen or antibody against it. Yeah.
Would it affect anything if the mom was like RH positive and then the baby was RH negative?
No, RH positive is not a problem because she's not going to respond to the.
So it's only like the baby wouldn't respond.
And this doesn't happen with the ABO blood groups, just RH. But yeah, she will attack. And so what they'll do is give her Rogam. Every time she's pregnant, they'll give her Rogam so she doesn't do this. So it prevents this problem. Most women are RH positive, but those who are RH negative get Rogam. Okay, so real quick. You can have the test on Thursday, or you can have the test after the break on Tuesday. If you want it Thursday, raise your hand. Okay, I got a few of you. If you want it the week after, the Tuesday after? Okay. All right, so we'll do it the Tuesday after. However, those of you who have it